Hey, good morning. Please take your seat. We are going to start. Please come in. This is definitely, Silvia, the most beautiful session of the Congress. So please come in.
We are ready.
I know that there are speakers for other session. I will be really happy to say the same for other session, but definitely
this
welcome.
Is the best one of the morning.
Yeah, this is the best of the moment, at least. So, welcome and good morning. I'm Francesco Cairo. I'm the president of CDP. I'm very happy to stay with you in this beautiful joint meeting with EAO and EAO. And she's Silvia Masiero. She's our general secretary from CDP side. It's a beautiful, incredible, and amazing event here in Milano. I think that it's time to start for the second picture. Great. This is the first one, but we have the other one. So a lot of Italian connection in this international meeting. Very happy to be in Milano. The first lecture will be Understanding and Managing the Soft Tissue at the Implant Site. Three incredible speakers, incredible lecture of 20 minutes of length, and then 10 minutes of discussion. Please, Silvia.
Hello everyone, welcome to Milan, and it's a great pleasure for me to be here with my president, Professor Cairo, the president of the Italian Society of Periodontology and Implantology. And it's a great pleasure to be here with all of you in this session that is dedicated obviously to implant and to the importance of soft tissues around the implant. But before starting introducing the three speakers and their lectures, please leave me the time to share with you a short video and then to share with you a similitude.
Break down my fears, I could, 'cause I feel good.
In the video, you have seen a mountain that is named the Giant's Tooth. It is in the Italian Alps, in the northwest part of Italy. And it is called like the tooth that we are going to discuss. It has a root, but never one ever seen the root because it is under meters and meters of ice. And this mountain, at the basis, has an area that is called the gingiva of the tool. It is a difficult area to reach, depending on the situation of the glacier, depending on the weather, depending on the season. But every alpinist that has to reach the top of the peak has to go in this zone. If we go in the other part of Italian Northern Alps, in the east part, and we go in the world-famous area of Dolomites, where no ice gingiva is present at the basis of the rock. These rocks are absolutely more fragile. So, I think that you have appreciated this similitude, also you, my president, and I leave you the honor to present then our speakers.
Lovely similitude, a great, beautiful image. And I think that it's time to start with the first lecture. It's a great honor and pleasure for me to introduce Professor Danny Busser from Bern University with his lecture, Hybrid Inverse Non-Hybrid Design Implants, Influence on Peri-Implant Soft Tissue Health. I think that you know very well who Danny Busser is. I want to underline that he is simply a giant of implant dentistry. Thank you very much, and please welcome him with your applause. Please, Professor Busser, please, Danny, come on podium.
Yeah, dear colleagues, thank you so much for this kind introduction. And of course, I feel like home when I see these mountains because I live very close to the mountains and to the Alps, and I see them all the time when I go to our weekend house. Okay, hybrid versus non-hybrid design implants. We are talking about the hardware, about the implant surface, and of course it will talk about the influence on peri-implant soft tissue health, but of course also peri-implant bone health. It's the tissue, not only the soft tissue, because the bone destructed when we have a problem. I give you greetings from my hometown Bern, and I show that because I remember with great pleasure 27 years ago when we had the EAO Congress in '97 in Bern. I was the first non-Bronnemark guy who had the pleasure to be the president of EAO, and we did the Congress in Bern. And you see here with André Schröder, the second honorary member of EAO, Hubertus Spiekermann, who was then the next president, and Klaus Lang. And we had 600 people and were extremely proud. It was a new record. And now we have 4,500. What an amazing development of EAO. And I can only congratulate EAO and of course also our Italian friends for this, that go into a team approach, and together they are hosting such a fantastic Congress. Okay, my journey in Bern has been for 40 years at the dental school. 5 years ago, when I retired as professor, I moved into private clinic, so I'm working there only about 25% of my time, just doing implant surgeries and seeing patients. And I concentrate on continuing education. Together with my friend Tony Sculian, we established an academy during the pandemic, because then we could only do streaming. And that's what we do with 2 master classes in the field of implants, GBR master class, aesthetic master course. And that's my main focus, knowledge sharing. When we look at 50 years of modern implant dentistry, we have to really be aware this is a fantastic success story of translational research, as it is called today. And we see all the milestones of the developments. You see, of course, the 2 giants in the beginning. You see P.A. Bronnemark, late 60s, and then early 70s, André Schröder from Bern. And they really, that was the fundament or the pioneer phase, and so on. And we will talk today only about one issue, that is the surface, because this is the topic of my lecture. If you want to read how this whole development and of course the open questions have been addressed, this is an extremely well-cited paper we have published in 2017. Hard to believe, already 7 years ago. Okay, when we look at the predictability of implant therapy, we have tons of 10-year studies that show excellent predictability, good long-term stability. So it seems everything is in order. When you look at the studies published by my team, 10-year studies, then we see that we have failure rates at 10 years below 2%, which is fabulous, because it's a very important number to patients when they ask me, what is my risk? I tell them, if we can stick to the protocols and you have a good hygiene and come to the maintenance care, then it's less than 2% that we're going to lose that implant in the next 10 years. And this is the kind of treatment we want to achieve, the outcomes. And you see, we go from 10 years on the left side to 38 years, my longest documented case so far. Patient is now 84 years old. I hope she will make it for the next 12 years. Then we will have once 50 years documented cases. It's impressive to see the peri-implant stability of the soft tissues and the bone tissues. And I always say this is the #1 goal of treatment when I treat a patient. We want to have a successful outcome, and it should be long-term stable. Let's say the median age of my patients today is more than 65 years, so I try to go for lifelong stability, so they will pass away once happily with these implants, as many of my patients have done so far already. So that's long-term stability is the key point. I'm sure we're going to talk about that in the discussion period. You see, The reality, however, is not so positive. I think we have to understand we see a lot of complications and failures in the field. I will not go through that list, but it's a real problem. And you see, when we look at the failure modes we have 4 different failure modes. And the most important one is actually failure by infection called peri-implantitis, as a progress to bone destruction due to a chronic infection or acute infection. That depends. So today we talk about failure by infection, peri-implantitis. When you look into the literature, you see it's frightening. There are 3 systematic reviews here from 17, 18, and 22, you see. And the prevalence of peri-implantitis based on these rather short-term studies are between 12% up to 28%, depending on the risk factors we have involved in these patients. So that's, of course, something you cannot accept, because when you would tell your patient, every 4th implant will fail due to infection, that is not a good selling argument when you try to propose a treatment plan. And you see, the risk factors have been determined, of course, in many, many consensus conferences. You see, it starts with the history of periodontitis, and the last one would be timing. You see, over time, of course, the prevalence goes up and so on. I think the 2 most important ones, the 2 most important risk factors is one, an exposed micro-rough implant surface to the sulcus, so the bacteria can populate a roughened surface, and unfortunately, the second one is poor surgical performance by the clinician, because that exposes that surface during the healing phase to the sulcus from beginning. This is a big problem we have. So when you look at the factors that influence a treatment outcome, this is from ITI Treatment Guide number 3, a chapter I've written together with Stephen Chen in 2008. It's clear to me we have 4 circles. The clinical team, that involves a surgeon, a prosthodontist or GP, then the technician, and of course also the dental hygienist to underscore the importance of maintenance care. It's the patient with all the risk factors they have, and then it's the treatment approaches. You have multiple options in a given situation, and you have to pick the right one, and then of course you have to also select the implants and the biomaterials to achieve good. But you see, the implant team is the largest circle, because I strongly believe that's 80% of the long-term success is in the hands of the clinical team, and therefore you need to have good education, skills, and experience. See, when we talk about surgery, to do 5 surgeries a year, this is complete nonsense, because you can never be a good surgeon. When we talk about the medical field, they talk about 50 to 100 procedures per year as a minimum, and that's the same in implant surgery. When we talk about implants, and of course it's the implant selection. So when we go back to our original slide here with our 2 giants, then of course we talk about surfaces. And this has been my first research topic in the late 1980s, because at that time we did have only 2 surfaces on the market. That was actually the Bronnemark surface, machined, and the TPS surface of first prototype implants of Straumann with the team of André Schröder. You see, we have had a lot of problems with the machine surface, long implants, bicortical stabilization, early failure rate of 3-4%, and so on and so on. But a big advantage was these implants obviously have not shown a lot of peri-implant infections. So the term peri-implantitis was defined actually by a Bernese paper from Andrea Mombelli in 1987, because these type F hollow cylinders with this micro-rough as a plasma-coated surface caused a lot of infections. You see, that was my first case I treated in 1984, 29 years follow-up, bar-type overdenture, and so on. In the mid-80s, then, it was decided we have to make next step of progress, and the second generation was created, and you see that actually we started to have a machine surface in the transcrestal area, the supracrestal area, to eliminate that risk of peri-implant infections, and a TPS surface inside the bone to improve endosseous anchorage. We did a lot of research in that field. These are just the two most important ones to evaluate different surfaces, and it was very obvious, a histometric study, a removal torque study, that actually one surface, the so-called SLA surface, showed the best results in terms of BIC, as it's called, and removal torque values. Therefore, we presented this study from 92, 93 at all these major conferences, steered a lot of discussions. The Swedes said there's no way to do because we're going to get a lot of infections, and we said no, we're going to improve many things as well. See? So we can say, you see, that these surfaces offered a lot of advantages, much better early success rates, shorter implants, shorter healing periods, and the dental market shifted. First paradigm shift in the let's say, second half of the 1990s. You see all major implant companies came up with a micro-rough implant surface. See? Then at that time, Dennis Tarnow came up and said, yeah, be careful, you see, we have to have a hybrid design implant, micro-rough for endosseous, but on top 3 millimeters machined. Otherwise, we run into troubles. I told him, of course, Dennis, you see, the tissue level implant I'm using is a hybrid implant, but of course, the problem is that then the whole market shifted, and I will show you that later on. In the meantime, I've seen many infections with implants that are micro-rough all the way up to the shoulder. You see, this is a typical immediate case that did not form the bone on the buccal. 9 years later, 29-year-old female patient has peri-implantitis ongoing, and now I don't know what they are doing. It's a patient from Brazil. Or these are severe cases, you see, infections with a complete destruction of the bone. Only here implant removal is the only solution, and of course, very difficult to handle case. We also see that with misangled implants. Here, Tony Scullion did a soft tissue graft to cover the recession. 2 years later, the infection came again, and after the third recurrence of peri-implantitis, then the referring dentist sent the patient to me to take care of it, and we took it off. So this is a big issue these days. 2015, then, Jan Dirks presented the data from a big study from Gothenburg, from a Swedish population, and they showed that non-hybrid implants have much less predictability than hybrid implants. You see here the odds ratio in terms of late implant losses, 5 or 6 times, and in terms of prevalence of peri-implantitis, 3 to 4 times higher prevalence. Then a really interesting study, 21, you see, from a Belgium group, almost 1,500 implants. They reported on early bone loss. And you see here the original figures from that paper, and I show you only one of them. This is actually early bone loss of 1 millimeter and more at 2 years. And this subgroup of these almost 1,500 implants showed 35% failures at the 10-year follow-up. I mean, that's frightening, you see. And when they analyzed the whole group, they had 5% failures and almost 12% prevalence of peri-implantitis. There was a study we did in Bern, you see, and I published that in 2012 with the group of Perio, Gianni Salvi. And by the way, they are analyzing now the same patient pool again for 22 years plus. And you see in this study, we had a failure rate of 1.2% and a peri-implantitis prevalence of 1.8% only, tissue level. When you compare now the two 10-year studies, you see the difference, 3% versus 17%. It's a strong indication that when you have an exposed surface, you have a problem with that one. Now you have to know that when we started with that study, we said that we are changing our protocol and put this roughened surface a millimeter below the crest, because I have seen in many of these TPS cases early 90s infections. So that was a protocol change in our vertical positioning of the implant. That's a really interesting study. It just came out, it's just online at the moment. You see from South Korea, Dr. Sung, together with Ronnie Jung and his team, and they actually have, in an animal setup, they have had 4 sites, 2 with a defect, 2 without defect, and then after 8 weeks of healing, they put ligature in 2 of them for 6 weeks only. 2 weeks later, they analyzed with histological sections. And you see here the whole setup. These are original pictures, and you see the ligated group with a defect. This is actually the LD group, showed by far the worst destruction of bone in such a short period of time. So the study, and this is the original conclusion, you see that he says an exposed surface, which is a micro rough surface because it was all the way up, showed the most destruction of bone. That study would be very interesting to see if that is done with a hybrid implant and 1 millimeter below. So when I was invited to the EAO Congress in San Diego, they also asked me to write an editorial on 40 years of experience in burn and what is the most striking problem in the moment. And I said, this is our infection rate in the market. And we have to move to hybrid implants to eliminate that risk factor rough surface in the transcrestal area. This is the paper as a guest editorial in the Academy News. So let me come to the conclusions. I will be on time. Okay. I think very important, there is no doubt we have a pandemic in the market. I was recently in Chicago, and I gave a lecture to a study club, and the lady, very prominent periodontist, she tells me 50% of my referrals today are peri-implantitis cases, how to fix them or to treat them. That's the problem. The problem is severe, it hurts us all. All of us are hurt by this, you see? And I think it's time that we acknowledge the problem, all stakeholders, including the companies, and we take action against it together. I'm also convinced that most of these complications are initiated at day of surgery by improper surgical technique leading to an exposed implant surface. Therefore, if you want to fight this problem, you see we have 2 areas of action. We have to revise our educational activities, universities, associations, and so on, to improve the surgical education and the clinical education of our clinicians. And we need a second paradigm shift, as we had in the mid-90s, towards hybrid implants. This is very important from my point of view. Okay, from a surgical point of view, you see, we have to select the right implant, put them in the right position, go subcrestally with the micro rough surface, and make sure that when healing is completed, this micro rough surface is fully osseointegrated circumferentially and is not exposed to the sulcus. That is the goal of surgery. And last but not least, keratinized mucosa. That's not the topic today in my lecture. It might come later on. So when you look at the market, we have a lot of hybrid implants in the market, but they are not pushed by the companies. It seems that these marketing guys do not understand the problem we have, because they are suffering as well in the mid to long term. So these are probably most of them of the major implant companies. So you are working with one of these implant systems, push your company to concentrate more on the development or improvement of these hybrid design implants. I'm sure you know that I'm using Straumann implants, and we did a lot of talks to Straumann since about 2016-18 to go in that direction. And finally now you see here we have We have the 4th generation of Straumann implants, which is a combination of the 2nd and the 3rd generation together with a hybrid design, TLX, TLC. And I use the TLX implant mainly for the molar sides because we have very prominent threads, and the TLC, which is a BLT improved implant, we are using in the aesthetic sides and in premolar sides. So I'm very happy that this straight version can be used with both prosthetic approaches that will simplify our daily practice significantly. So when we have a summary, you see the slogan is, let's push hybrid implants and let's foster education all together to fight the problem of peri-implantitis because it's all in our favor for the patient, for the companies, and of course for the dental offices. If you want to have my lecture as a PDF, feel free to send an email to this email address. If you want to learn from a top faculty, actually next week in aesthetics, you see here most of these speakers are here. Streaming technology allows that. We have an excellent streaming platform. Then take your chance and give us an email, and then we give you an EAO special rate for this online participation. Thank you very much.
Thank you, Daniel. And you have to remember that if you want to ask questions, you have the app of the EAO, and we will receive the question that you want to feel perceived by our speakers. And now I have to introduce the second speaker. She's a woman. She's Ana Torres from Spain. She has a different topic. As you have seen, we started from the root, and perhaps we could imagine also the continuing of the similitude if we are thinking about what is peri-implantitis for our mountains. Perhaps peri-implantitis is considering the changing of the weather that gives the area near the mountains very, very difficult to approach. But now we go to the peak with Anna. She is talking about a different topic, but in the same theme. And she's talking about prosthetic, about the abutment design at the level of soft tissue. So she's up to the peak, but she starts from the area of gingiva. Mm-hmm. Have a good talk. The podium is for you, Anna.
Yes, thank you very much. Should I use this?
No, perhaps you have to use this.
Okay. Okay. Well, good morning, everyone. Thank you, Silvia, for your presentation. My first words of gratitude to the EAO Organization Committee and to the Italian Society of Periodontology for this very, very kind invitation. It's such an honor to be here talking with you, where I will be talking about the abutment design at the level of the soft tissues. Whenever placing an implant, we differentiate between two areas or components: the infracrestal component, attaching the implant and its surrounding tissues, and the supracrestal component and its relation with what we call the transmucosal area. Today, we will be focused in the supracrestal component and its implications. It is well known that what we expect from the peri-implant soft tissues is a biological union, where our ultimate goal would be to achieve an hemidesmosome adhesion in the epithelial part and a connective tissue that embraces our abutment, and this way isolate the implant and the bone from the bioma. A second objective would be to achieve an interrelation between the restoration and the soft tissues, where it is important to remark that the design of the abutment has an impact on the final aesthetic outcome. So what factors may influence the peri-implant soft tissues, and how can we interfere or modify as clinicians, not only to achieve the highest harmony, but also situation healthy and free of inflammation? Well, this meta-analysis analyzed the regarding evidence regarding the surface topography, the contamination method, macroscopic design, and material of choice. Whether we know that it's still a scarce evidence for the first three concepts, it seems that the material of choice seems to have a positive effect in the maintenance of the soft tissue health. Our goal now is to fabricate a restoration that is going to harmonize with the surrounding soft tissues of the patient. And today, we will be focused in the provisional restoration. So how should be customized a provisional prosthesis? In 2010, were published the critical and subcritical concepts, macroscopic concepts that will guide the soft tissues during the maturation or healing to ensure the aesthetic outcome when having to place the final restoration, that differentiates two areas: the critical contour, that it's located immediately apical to the gingival margin, and where changes in the facial and interproximal area will have an impact in the gingival margin, zenith, and anatomy of the clinical crown. And the subcritical contour, that it's located immediately apical to the critical contour, and when sufficient room is available, changes in this area will have an impact in the soft tissue volume. In order to be able to clinically apply these concepts, two factors must be taken into consideration. The first one is that we must count on optimal soft and bone tissue contours. And in the cases where there is a lack of it, we should think about surgical augmentation procedures. The second key that I would like to address is that all those changes should be either incremental or detrimental. It is the duty of the clinician to modify and sculpt the tissues little by little to harmonize with the surrounding situation. And we can do this in immediate implants or after maturation of the tissues. So how should be sculpt the transmucosal zone in immediate provisionals with immediate implants? The main purpose when placing immediate provisionals with immediate implants is to support the already soft tissue architecture and avoid the collapse during maturation or healing. There are several ways to create an emergence profile for an immediate provisional, and all of them should follow the same principles. What we propose is to create this emergence profile before placing the implant, and this has several advantages. The first one is that it saves post-chirurgical time. The second one is that we're going to keep the surgical site protected. And the third one is that we make sure that we're going to get a perfectly polished and adapted emergence profile. Well, unfortunately, we don't have time enough to show you the step-by-step, but I'm sure some of you are already using the same protocol. The second objective is to avoid the soft tissue compression. Every time we place a provisional in an immediate implant and we see ischemia, we remove it and release it until no pressure is seen. That's why we prefer profiles as concave as possible when placing these emergence profiles, and we have evidence for so many years proving this. And making a subcritical contour flat or concave, it's going to provide this soft tissue stability, while placing a subcritical contour convex will promote the migration or collapse of the tissues. This green zone here between the restoration and the soft tissue is the key area. It's the regeneration space that is going to allow the blood clot formation and a correct maturation of the tissues. Whether a subcritical contour that is convex will occupy this space and won't allow this blood clot formation, promoting the migration or collapse of the tissues. So the main objectives of these temporary restorations in immediate implants is to create a subcritical contour allowing a regeneration space for the blood clot formation and a critical contour that is going to seal the whole perimeter without making any pressure. So immediate provisionals in immediate implants are indicated when the already existing architecture is okay. After making an atraumatic extraction and placing the implant, we're going to try the emergence profile, making sure that the subcritical contour is going to be flat or concave to allow this regeneration space, this blood clot formation that is going to allow the maturation or healing of the tissues. Whether placing a provisional with a subcritical contour convex, it's not going to allow this blood clot formation, and it's going to promote the migration or collapse of the tissues. However, after maturation of the tissues, some modifications of the prosthetic contours may still be needed. Now is the moment where we are going to produce controlled pressure and ischemia over the tissues if we want to move the tissues, or we're going to release the provisional in case we want to gain volume or move the tissues into a more coronal position. 4 different scenarios can be seen after maturation of the tissues: over-augmented ridges, ideal situations, slightly deficient ridges, and ridges with major discrepancies. In the first 3 scenarios, modifications of the prosthetic contours should be made. Whether in ridges with major discrepancies, surgical augmentation procedures must be taken into consideration to overcome this problem. Establishing the critical contour is the first step in our conditioning process. In a case like this one, where after maturation of the tissues we could see how we had an over-augmented ridge, the critical contour had to be moved into a more apical position. Remember that the critical contour is located apical to the mucosal margin, and whenever we need to move it, we need to add increments to our provisional apically to this position. And this is what was done to the provisional of this patient. Adding increments of flowable composite apically to the mucosal margin and making controlled pressure over the tissues. I'm sure that most of you already use the same protocol, but this is how we modify the provisional chair side whenever we need to modify these contours. We sandblast with aluminum oxide particles, followed by an adhesive application. Then we apply nanohybrid flowable composite, and finally we pay special attention to the polishing step to avoid discoloration or plaque retention. Whenever we need to move the tissues, the critical contour into a more apical position, and we make controlled pressure, no more than 10 minutes of ischemia should be seen. This is after making all the modifications, achieving quite acceptable results and a happy patient. In this other case, where an implant in the 1.1 had to be placed, after maturation of the tissues with the provisional restoration, we could see how the critical contour and the gingival or mucosal margins were correctly nivelated. However, sometimes after maturation of the tissue, or the tissues, due to the soft tissue volume loss, changes in the color appearance of the soft tissue might appear. This is where the second step is to condition the subcritical contour or subcritical area. We remove the provisional, and the first requirement is that we count on enough soft tissue volume at the buccal part. Also, another requirement is that the implant is deep enough, that we have enough room to make these modifications. If the implant is too superficial, the subcritical contour concept becomes meaningless from a clinical point of view. So the subcritical contour adjustment is whenever we make these changes in between the critical contour and the neck of the implant. Finally, we can transfer the final situation to the final restoration, seeing that we could overcome this problem for the patient. In 2020, an updated version of contour modification was published, differentiating between immediate implants and provisionals after maturation of the tissues, where in immediate implants, the subcritical contour should be always kept concave. In a late implant situation, these modifications should be made depending on the final position of the ridge or the depth and position of the implant. Finally, when we have conditioned all the process, this transmucosal area can be transferred to the definitive restoration. And this can be done analogically, like it's been done classically, customizing an impression copying and taking an analogical impression, or digitally. We can copy this emergence profile for the definitive restoration with a CAD/CAM system. We have proposed a fully digital way to be able to transfer this situation to the final restoration. The inverse scan body concept. Well, after modifying the contours in the provisional phase, we're going to transfer the situation to the final restoration. And this can be done via two different STLs. The first one is scanning the provisional with what we call the inverse scan body. And the second one is scanning the patient, making a biocopy of the situation of the patient. And this way, we're going to be able to transfer this transmucosal area to the definitive restoration. So finally, as clinicians, we should be able to fully understand the impact of these modifications to the final aesthetic outcome of the restorations of our patients, where we know that changes in the critical contour will have an impact in the zenith, margin level, and anatomy of the clinical crown, and changes in the subcritical contour will have an impact in the root convexity and soft tissue color. Thank you so much.
Thank you very much, Anna. Thank you very much for your lecture. And now it's time for having on stage the speaker number 3. Fortunately, I've got a conflict of interest with him because he's my vice president. He's a very good friend of mine, Dr. Lello Cavalcanti, but he's also one of the most important and skilled clinicians that I know. So I think that this lecture is going to be really interesting and amazing, and it will be on can soft tissue be predictably manipulated for long-term stability. Welcome on podium, Lello.
Thank you, Francesco. Thank you for your kind introduction and presentation. So they understood why you are so kind with me, because we are very close friends, great friends, and we share a lot of things in our life and daily profession. So my title is a question. I can very briefly answer yes, and we can go on, or we can do something different, try to get the focus of this topic, answering some other question. One that for me is very important, and I hope you think the same, is what is our real target and first outcome of our implant treatment? Is soft tissue margin stability long-term, or more important, as Professor Busser said before, long-term peri-implant health? And these are the 4 questions I will try to answer. I skip. Peri-implantel has been very well defined in all the publication and papers that are the basis of the current classification of periodontal and peri-implant disease. So these are the most important point, but I like to switch your attention on that beautiful histology given to me by our friends Maurizio Araujo that I think very well represents sound peri-implant tissues at bone level and at soft tissue level. And we know that just around the corner, complications are as biological complication and aesthetic complication. And we have to now try to attain our purposes, our success criteria. Let me say, analyze from different point of view, the implant and the bone level, the peri-implant tissue that received much more emphasis in the last years, the prosthetic level, avoiding major complication, and now also the patient satisfaction, the PROMs. In our daily practice in 2024, I think we can understand that a patient like this cannot accept this type of result after an implant treatment and after a prosthetic restoration of a perfectly integrated implant. This is the situation after a very complex treatment with different surgical steps after implant removal. The other aspect, marginal soft tissue recession around implants. They have several causes, several factors that may influence them. And some of them are really located in a very precise area, that is the 3D implant position. Implant has to be placed in the comfort zone, the lack of buccal bone, the thin soft tissue, the soft tissue phenotype, and some other aspects that are also related to the surgical steps and to the surgical trauma that we may given to peri-implant tissues. And we have some predisposing factors at different levels, different substrate, hard tissue level and soft tissue level. A recent series of publications coming from the last ITI Consensus Conference give us some information and some very precise address about these two levels. The bone one, with an evidence supported by a systematic review based on 12 clinical studies about the amount of bone that should surround our implants, 1 millimeters, 1.5, but in my opinion, 2 millimeters is a more comfort zone. And on the other side, on the other aspect, on the other end, the soft tissue augmentation procedures, the STA, to change tissue phenotype that gives an added value to the bone regeneration process that may have been performed beneath the tissue. Let me show this clinical case that is a case, a hopeless canine in a patient with a history of periodontitis, as you can understand from these clinical pictures. What happens after a very easy tooth removal is, in the first 8 weeks, was what was very well described by Viviane Chapuis in her publication in 2015. After, like something magical, after 8 weeks, this soft tissue increase spontaneously and give us enough tissue, enough stuff to perform our peri-implant surgery that in this case, like in every case of type 2 implants, may provide a perfect implant position at the bone level together with a simultaneous bone regeneration procedure in a multi-layer model, bone, autogenous bone on the implant surface, then xenograft, and with the comfort, with the support of the literature, the papers published by EAO President Ronnie Young with very significant long-term results about the efficacy of the procedure and the stability of these tissues long-term. But this is a patient, periodontal patient, with a thin phenotype. So we may try, we may get advantage from soft tissue augmentation in order to protect that amount of regenerated bone and to guarantee peri-implant health time after time. So a small connective tissue graft was placed on the buccal aspect of the implant. It is the situation with the stable tissue 3 years later, and you can compare the implant phenotype with the adjacent teeth ones. So site-specifically, we changed that phenotype, and this is the 7 years radiographic bidimensional image with a stable bone level on the mesial and distal aspect, and also we have evidence coming from the Bern School since a long time ago. In the title of my presentation, the term long-term issue, long-term has a very important significance. So what does it mean? Whole case, now more than 15 years ago, hopeless tooth, not so easy to remove without fracture it, major defect, critical size defect, bone regeneration procedure simultaneously to tooth removal in order to avoid the soft tissue collapse in that major defect, difficult primary closure, re-entry for implant placement with some additional contour augmentation, and the way we did at the time a connective tissue graft that protecting everything. Submerged healing, second stage, and this is the clinical and radiographical scenario 18 months later. This is 8 years later. This patient underwent a CT scan for different purposes. Everything is stable. And at 10 years also, everything is stable. The synergy between the bone that was still present on the buccal aspect of the implant and the soft tissue, I think, is the winning component. And what can happen on the other end when we do not perform soft tissue augmentation? Almost the same age, 2010, 2011, patient, classical patient with lateral upper incisor agenesis, replaced by 2 implants, a very limited, a minor bone contour augmentation without no soft tissue augmentation. The initial situation after the completion of the implant treatment, 2012, something is happening. Tissues, the biotype and phenotype in this case are thin, so they, despite the fact that at the time of implant placement of the second surgery, the crestal tissue was pushed forward in the buccal direction, but the phenotype didn't change. That is not a way to change site phenotype. So 2015, 2018, 2022, and the patient is really unhappy now. We have the possibility, we first of all wanted to verify the bone contour, whether or not some bone thickness was already there, and bone tissue was there, so we were supported in our decision with a minimally invasive, creating a pouch, a kind of tunnel connective tissue graft placement, in order to change prosthetic crowns, of course, but mainly tissue phenotype. This is 1 week later, 10 days later, that suture removal, the prosthetic workflow, tissue conditioning, the new implant crown supporting before their placement in the mouth of the patient and with an X-ray control, and the final restoration in place. Piero Venezia, that is there in the second row, and you will have the possibility to listen on Saturday morning, is the responsible of all the prosthetic treatment that you saw before. So changing the phenotype, also in order to get the best aesthetic result in terms of papilla score, pink aesthetic score, papilla preservation satisfaction, and less recession over time, which is our approach now. Our approach is supported also by this publication, that is a retrospective study, almost 100 patients, almost 200 implants, with at least 5 years follow-up. Our approach now is to combine, even in different steps, bone regeneration procedures simultaneous to implant placement with soft tissue augmentation. In this case, the digital planning was aimed to understand whether narrow diameter implants can be placed with the option of receiving simultaneous bone augmentation. As you can see here, at the time of implant connection, second surgery, we placed our connective tissue graft. So this is the result immediately before placing the final crowns. And what we saw substantially is that, of course, the bone regeneration procedure was reliable, everything was stable, but 1/3 of the implants that received the soft tissue augmentation had substantially a stable position of the soft tissue margin with almost no recession and sometimes also some tissue overgrowth in coronal direction. This approach can also give us the possibility to satisfy the patient perception. As you can see here, we have 2 implant-supported crown and 2 natural teeth without no possibility to understand which is the artificial one compared to the natural one. We are studying now as a group with Francesco and all the friends from University of Florence, Luigi Barbato is there, also the possibility of utilizing alternatives to autologous soft tissue graft in terms of collagen matrices that you all know that are now an option, but we have really to understand in which terms they could be a reliable option. Natural tooth, root fracture, fistula, infection, no alternative to remove the tooth, wait for an early implant placement, 2 months. This is the expected overall tissue shrinkage, and we know that placing the implants, we would need to add some adjunctive procedures. In this case, as you can see, we are elevating a full thickness flap for the first part, then a split thickness flap for the apical component, implant site preparation by guided surgery, implant placement freehand, regenerative procedure, autogenous bone, xenograft, and collagen membranes that is stabilized with titanium pins, the suture in order to get a primary closure. 4 months later, second surgery, in this case we decided to try the possibility and the outcome with the collagen matrix. The flap was elevated in a split thickness manner in order to stabilize the matrix. You can see the initial tissue volume increase. This is the situation a few weeks after the final crown placed. The X-ray is taken 1 year later. And this is the situation 2 years before. This case is the pilot case of an RCT that we are completing in next weeks and with 100 patients treated, 50 with connective tissue graft, randomly, of course, assigned versus collagen methods. And let me share with you this final case, because this situation is really something that could have a very important psychological aspect on a young girl, 26, 27 years, who received a really traumatic tooth extraction with this type of outcome at superficial tissue level and also for the bone component. The first surgery, so surgery number 1, flap elevation, need to remove some root remnants because probably the tooth was ankylosed and really the extraction was very, very traumatic for the patient, very, very aggressive. And during this first surgery, we tried with the grafting that site with a connective tissue graft to get enough tissue to perform our regenerative subsequent procedures. So this is after some tooth maturation, 3-4 months later. In this case, we need something more, so a rigid scaffold to perform our bone regeneration. This is a customized titanium mesh, a combination of autogenous bone together with xenograft. 9 months later, implant placement, additional bone contour. Everything was submerged. You can see here the collagen membrane that is fixed by titanium pins. 4 months later, 4th surgery, but the one that, in this case for me, has been really determinant for the final outcome. Split thickness flap, connective tissue graft, and in this case, the abutment was placed. Everything healed about that abutment. It's time for provisional restoration placement for soft tissue condition. The final outcome, the before and after comparison, and the 5 years follow-up, because this is a medium-term follow-up. Of course, 8-10 years would be more significant, but I think that something is so stable after 5 years, it could be the same after more and more years. So my final consideration about the advantage of soft tissue augmentation are that in order to get our primary outcome, so to prevent peri-implant disease, soft tissue can adequate tissue thickness can really work as a factor to prevent peri-implant diseases, and of course on the aesthetic side, thin peri-implant tissues are more associated with marginal tissue recession. So to have a thick phenotype also gives more favorable and long-term stable also aesthetic results. As the title of the Congress says, details make perfection. And I like to just to show you that clinical picture, 2 natural teeth, central incisor, canine, and an artificial one, an implant-supported crown, for another case of this is monolateral teeth agenesis. So I thank you for your attention. I come from the south. I left the sun yesterday when I left from Bari, and I invite all of you to visit our beautiful land that is Puglia. Thank you very much.
I now invite.
Vai di lato. Thank you, Lello. May I ask you to Danny and Anna to come on podium? We have 10 minutes for discussion. Please don't go. Where are you going? Please stay with us. We are going to have 10 beautiful minutes of discussion, beautiful question from the audience. Thank you very much for following us. And the first question is for Professor Buser. Danny, very short question and very short, please, answer. And my personal question is, what is, from your incredible experience, from your incredible perspective, more than 35 years of experience in implant dentistry, what are the most important concepts that have changed over the 3 decades in order, to understand what we have to do now in order to have stability around dental implants? For example, platform switching, what are your, milestones that you are going to identify in literature?
Okay, I think most important is the tissue biology understanding what happens post-extraction. Because we are doing, at least in my clinic, 80% of the implants I place are post-extraction cases. And you need to understand how the tissue heals, and we cannot change the tissue biology because it's all driven by the genetics. And I think the paper by Maurizio has been an eye-opener in 2005 to have a better understanding. And depending on the local site analysis, then you have to make a decision. I can do an immediate implant placement, I do an early placement, or do soccer grafting, and I do delayed placement. All of them work. And it's not a question of religion, it is case selection. I think we have to stop this nonsense at conferences to have battle discussions, what's better and so on. It all depends on case selection. And therefore also here with hard tissue augmentation, bone augmentation, I think when I need soft tissue augmentation, of course, if I can do it myself, I do it myself, or I ask Tony to do it from me when it's very tricky because he's much more experienced. So I think this is what we learned on this tissue biology issue.
Thank you.
There is a question for Anna, and someone asked you, what do you mean saying that the implant has to be positioned deep enough? And I suggest also the other 2 speakers to say what they mean by their own answering this question.
So in other words, what means the perfect 3D position today in the apical coronal dimension for you?
Well, for me, we speak from a prosto point of view, and it's whenever we have enough running room from the neck of the implant to the gingival margin in order to be able to make these modifications whenever it's necessary after maturation of the tissues. So, of course, I always work by the hand of Oscar González, that is the head surgeon of the private practice where we work, and he ideally is always place the implant apically to the cementum enamel junction of the adjacent tooth, taking into consideration if he needs or not, or we need augmentation, surgical augmentation procedures for the tissues, and after maturation, we need to count on, especially, that we have enough running room for the subcritical contour and the critical one in order to be able to modify them.
Thank you. Danny or Lello, do you want to add something?
Yes, of course. I think it's important that she talks about aesthetic restorations. That's 30% of the cases we do. Yeah. And all the others are non-aesthetic, they are more in the posterior, and that's a complete different story. Because there the prosthodontists want to have the implant shoulder probably a millimeter submucosally, and that's about it. Because it's much easier to access. But in the aesthetics, I fully agree. I mean, ITI has confirmed already many years ago it should be about 3 millimeters, so that you have enough space for your vario-based abutment, whatever you see, to have this development. And the implant is also slightly more palatal, so you need to develop this contour. I fully agree with that one. But we have to differentiate aesthetics, non-aesthetics.
I think that your suggestion is really critical, and as a periodontist, I strongly believe that sometimes soft tissue resection at the posterior side in periodontal patient is useful to have a very shallow tunnel.
Absolutely.
Please.
And my answer is something, the statement that Danny knows very well. As deep as necessary, as shallow as possible, in different scenarios from 2 points of view. Anterior versus posterior, and healthy patients versus patients coming from an history of periodontitis. So completely different environment, case-by-case selection, and different strategies. About the aesthetic area, my input would be to not place the implant too deep. But now, working with Piero, I understood also to calculate the space, the distance, as Anna told, that he needs to develop his best possible emergent profile.
Okay, thank you. There are two very nice questions in order to clarify some issue in your lecture. The first is for Anna. What could be the perfect timeline from a clinical standpoint in order to have, the perfect position of the gingival margin before the final impression?
So after maturation of the tissues, when we start making these incremental changes, either adding or releasing volumes, we wait in between increments to make the follow-up, 1 week, 10 days in between the sessions. And then we wait like 1 month or so to take the final impression. So we can see the complete stability of the tissue at the end.
Okay, please.
And someone asked if is there a possible connection from, possibility of influence on the long-term stability of the implants, depending on the connection type that we have near implants, and depending on the positioning of the implant subcrestally or at the level of the bone crest.
Please, then.
I have a clear opinion, of course. First of all, we did not discuss today microgap. Huge issue, because all the research we have done with David Cochran in the late 1990s, because we all know when we have a microgap with some micromovement on top of that, and the microgap is 20 to 50 microns, you have a chronic infiltrate at the microgap, and that initiates actually then the remodeling and then the downgrowth of epithelium beyond the microgap. So what I see now, I mentioned very briefly, but didn't have more time, with this, let's say, fourth generation, of course, we not only combined a tissue-level concept in terms of hybrid implants and the shape of the tapered implant, but we also included a new connection called TorqueFit. And what I see now in my patients, and we have 80 patients now, there is much less remodeling at the implant shoulder when there is a tissue-level prosthetics. So it seems to me that the stability is better and the microgap seems to be less in size. This needs to be confirmed now in preclinical research. They will do it in the lab of the processor by Burak Yilmaz, and then we will confirm that hopefully. You see. But there is a potential to improve as well. But subcrestal position is very important. I said long-term must be the vision. And you see, to put an implant with rough surface to the bone crest is a big mistake, because there is a standard deviation. 20% show more bone resorption than the others, and you have from beginning a risk factors installed in your patient. Go down, and then you eliminate that.
Very important. The last question is for Lello. You show a beautiful case of soft tissue augmentation. I mean, do you believe that there is the perfect timeline for soft tissue augmentation before, during implant application, and after? Could you cluster, some ideas to exchange them for the audience?
There is not a perfect timeline, of course. We have to decide on a case-by-case basis, and we have different options. In some patients, we try a big advantage, increasing soft tissue thickness, for instance, by means of a free gingival graft before implant placement. Quite often, we use the second surgery, if it's provided one, to increase soft tissue thickness. Sometimes it happened to me, mainly in the posterior area, to utilize that window from implant placement with simultaneous bone regeneration procedure, with a submerged healing phase, to utilize that 4 months that we traditionally wait before implant connection to place in the posterior area free gingival graft to increase soft tissue thickness, and so to be ready for the second stage. So we have different timing before implant placement, time of implant placement, the second surgery, and sometimes after some years of implant in place.
Danny, please.
Can I ask you a question?
Yes.
What is your feeling right now? Because you do this randomized study, which is very important,
Yes.
that we can replace connective tissue grafts as autologous material in the future, or for very dramatic cases, you still need it?
For many cases, we still need it. Connective tissue graft always still wins. We have some promising results in terms of mucosal margin stability after 1 year in the study that we are now completing with Francesco. What is more different variable between also one individual to the other is to maintain the soft tissue thickness, so to change the phenotype by means of a collagen matrix.
Okay.
If we want to change the phenotype, we have to place something that is autogenous and probably works as something that is covered, connected to the blood supply, but tissue of different origins. So we change the phenotype with 2 different layers of tissue. The native one there, the flap, and the additional one, the graft taken from other part of the mouth.
Okay.
Thank you.
Okay, thank you very much, dear friends. You did a really beautiful lecture and a beautiful discussion too. Thank you very much.
Thank you very much. Thank you to all of you.
Let's take a picture.
A lot of suggestions,
please.
but the course is only at its first day, so enjoy the other
Enjoy
section of this
the EAO
wonderful
CDP
course.
EAO meeting and see you. Grazie.
Bye, see you.